Welcome everybody to the Demography Workshop. I'd like to introduce our speaker for today. Our speaker is Naoko Muramatsu, PhD, who is professor in the Division of Community Health Sciences at the School of Public Health and fellow at the Institute for Health Research and Policy at the University of Illinois, Chicago. She is trained in health service research and sociology with sort of specialization in demography and organizational studies. Dr. Muramatsu investigates aging and health in individual, social, and healthcare contexts with the goal of improving the quality of life of older adults and people who care for them locally, nationally, and globally, which is going to be the subject of today's talk. As PI and co-I on University Foundation, CDC, and NIH-funded grants, Dr. Muramatsu conducted studies on aging, health, caregiving, formal and informal support, healthcare access, and workplace health. She is a fellow of the Gerontological Society of America. So welcome, Dr. Muramatsu. Look forward to your talk.
Thank you very much, Albert. And thank you very much for the invitation. I'm very happy to see all of you. So today's talk is Global Aging, Building Health Promotion and Equity into Home and Community-Based Services. So we are getting into an unprecedented time. For the first time in history, starting in 2016, we are living in a world where we have more older people than younger children. This graph shows the percentage of younger children, this graph shows the percentage of young children continue to decrease, and that of older people is rapidly growing. So this is the world where we do research. So today, I would like to have all of us zoom out of our focused research to take a look at the aging issues from a global perspective, and then place our focused research back into the global context. So I will start with some background information, and then I would like to touch upon two studies that I have conducted. One is related to state long-term care policy, and then the other one is ProHome, that is a study to build health promotion into home care. And I would like to set aside time for question and answer so that we can engage in discussion. So this graph shows the trend of population aging of Western and East Asian countries. So there are two things to note. Western countries like France, Sweden, Germany, UK, and the United States were much older than Japan or China or Korea. So, but by mid-21st centuries, as you can see, the Asian population will be older than the population in the West. And also, I can put my life, the whole life, into this diagram. I don't tell you where I start, but I can tell you that I came to the States from Japan in 1988, and I studied my graduate studies there. So at that time, American population here, shown in yellow, was older than a Japanese population. And I remember seeing many groups of Japanese people arriving at the University of Michigan campus and then learn about long-term care system in the United States. And Japan sent lots of people to Scandinavian countries and Germany to learn different systems, because Japan knew that this rapid population aging is going to happen. So now Japan is the oldest country in the world in terms of the proportion of people who are, age 65 and older. And this diagram shows the population pyramid of 1990, 2010, 2025, and 2060. And as you can see, that the population pyramid, which used to be bottom heavy, has become very top heavy and then becoming very slender, meaning the population is shrinking. And also you can see that the proportion of people aged 65 and older grew from 7% in 1990 to, approximately 1/4, 25% or so. And then by 2060, it becomes like 40%. And more dramatic is this population aged 75 and older. It has grown from 5% to 11% and eventually to 27%. So this is really dramatic. And also there are fewer working populations supporting older people. It used to be 1 to 5, and it will become almost 1 to 1. So this is a dramatic, societal changes that are ongoing. And you may be wondering what this pink line is. Pink line is basically baby boomers. So it is interesting that, in the United States, baby boomers really were born in like 1946 to like a 1960 something. But here in Japan, it just continued 2 years. And after 2 years, the government was afraid of having too many people on that island. And so they, introduced some kind of image of ideal families with 2 kids. And growing up in my, class, in my cohort, there were only 2 or 3 kids who had like a 1-child family or 3, child family. So everybody had 2 kids. So that's why this birth rate is, going down. And the green line shows the second birth, basically second baby boomers. Okay, so this is the picture. And so, once people are born, majority of people survive. And so as of 1980s, Japan knew that this super aging society is coming. And starting in 1980s, Japan started preparing for that society with lots of older people. And they started introducing home care, which didn't exist before. And then the major policy change occurred in 2000. So Japan established this long-term care insurance system with the slogan, from family care to care by society. And then they changed this means-tested long-term care system to universal social insurance. So if you become age 40, then you will start paying into the system. And then in order to receive services, you need to be 65 and older. And you need to have physical, mental health needs. And regardless of income or family availability, people can receive services. And here, municipal governments are insurance, and there is a nationwide standardized needs assessment. And so people who apply for this insurance services, they are categorized into care support and care need levels 1 to 5. So there are 7 levels of care needs. So according to this level of care, people can receive a certain number of, hours of, amount of services that they need. So when it started in 2000, it's amazing. It's already 22 years ago. But I thought that my dad is the last person to utilize this kind of services. I couldn't think of him going to kind of group-based, program like daycare service. Turns out that lots of health issues, and actually he started using it, and he actually went to day services, and that was amazing. And also, it's amazing how quickly this system has been accepted in society. So people think that, well, Japan, well, family care systems may be very strong, but actually the norm changes over time. And so that system started just when, the caregiving kind of responsibilities, norms have started changing. So, so it was amazing that my dad used to have like a Christmas card or New Year's card exchanges, and people talk about, oh, I have been promoted to care level 3, and people talk about their care level needs in their annual exchanges of season greetings. And then, so my mother, who could hike in the mountain with us 2 years ago before the COVID pandemic, her spine broke. There was a bone problems with osteoporosis, and she's now homebound. And she didn't want to get into this system, but we really encouraged. And then finally, she agreed to get this test. And then she was categorized as someone who needs the least services. And then she started going to day service once a week. And actually, this is something that she now looks forward to. So it's amazing how quickly things change, and also the norms change. And also, even before she needed care, she started going to like municipal programs, like exercise programs, like the one that you see in this screen, on this screen. And so, it's amazing how this system is really, accepted into people's lives. So this universal long-term care insurance is really significant because it made long-term care access the right of all people 65 and older, not a welfare program. This is a program that that is available for everybody, and also it incorporates care prevention. And so this exercise is one of the things that people do in this system. So I would like to share this diagram. Many people here have seen this probably, but this is a survival curve model. And the x-axis represents age, and 30 to 100. And then survival probability is shown on the y-axis. And there are three curves here, a mortality curve, and a disability curve, and then mobility curve. And so that means, like, at the age of 30, almost 100% of people who are born are surviving. And then gradually people die. And then at the age of 90, 100, people, die. Now, the area below this line indicates the person years lived. And the line disability line, and the area below that is the person years lived without disability. And the area below the mobility line represents years lived without mobility. So basically, public health approach is to try to prevent mortality, so that this outer line will go outside, and also try to delay the onset of disability and the onset of mobility. And also we would like to reduce the area between these lines. So for example, the area between mortality and disability indicates a person years lived with disability. So we would like to reduce that area so that we will have less caregiving needs, or medical healthcare needs. So that is this is the diagram that guided me since my graduate school years to do this research. What are the strategies to reduce this area between these lines, and also how to improve the quality of life of those people who are living between these lines? So naturally, coming from Japan, I always had this comparative perspectives comparing Japan and the United States. And once I settled here in the States, I looked at state-to-state variation in long-term care. And I'm currently doing intervention research in the city of Chicago. So in the United States, as you know, there's no real long-term care coverage, public coverage except for the poor. And Medicaid is the largest funder of long-term care. And there has been progress towards expanding home and community-based services as opposed to nursing home care. These services include home care, adult daycare, nutrition and transportation services, those services to help avoid or delay nursing home admission. And again, public long-term care is financed by Medicaid, Old Americans Act, Social Service Block Grants, state general funds, etc. But the thing is, there's a large state-to-state variation in long-term care policies and financing and the delivery systems, because Medicaid is a state federal program. And so Medicaid's eligibility and services that are provided are determined at the state level. So I wanted to see, basically my research generally aims to understand aging and healthcare experiences of older adults and their caregivers in social and cultural contexts, and to improve healthcare access, quality, equity, locally and globally, especially among those people who are frail and old, in order to maximize daily activity function. So I take various approaches, including quantitative analysis of large longitudinal multi-level data and mixed methods, and then do some case studies or focus group to get some in-depth understanding of the phenomena. And now I am conducting randomized control trial. So I would like to briefly introduce what I did previously to look at state variations. And I really wanted to find out how these state-to-state variations are manifested in people's real lives. And so I looked at well-being broadly defined. And I looked at nursing home admission, place of death, and also mental health, combining the data compiled at the state level and county level. And I combined those macro level data to individual level data using HRS, 10 years of HRS data to look at individual level factors and various factors that impact this phenomena that I have been interested in. So this is one of the results that I found. So this diagram shows on the x-axis home and community-based services expenditure per person in each state that ranged from $35 to more than 1,000 at the time. And then the y-axis indicates the hazard of nursing home admission. And so what this graph shows is that the state home and community-based services support delays or prevents first nursing home admission and among childless seniors. So there are three lines. The solid line represents people without children, and the next line, dotted line, represents people who have children but they don't live together. And then the bottom line shows children who live nearby or live together. So as you can see that there's a lower chance of getting into nursing home among people who have kids nearby or live together. So that is understandable. And then the next one is there's no child nearby. And this decline comes from people who don't have children. So this indicates that for these people, whether you're living in the state with higher support level has less less nursing home admission chance, and then it makes a difference, where you live. Whereas all those people who have kids, where people live didn't matter very much. So there's a general findings, and so in general, we found that where older adults live matters for those people for their well-being. And living in a state with higher HCBS support was associated with greater well-being among community dwelling seniors with functional limitations, especially among those with limited family support. So it makes sense. If you have family will take care of you. But if you don't have family, whether you live in an environment where there are, community services available for you, that makes a big difference. And also in general, we found that the individual attributes and the immediate social context matter, compared to distant contexts, like state environment. Unless you really need this kind of services, people are not aware of the differences across states. And only when they, when you don't have anybody to take care of you, then you realize the importance of this state policy or state resources. So yes, so this research, supports the kind of general notion that increasing support for home and community-based services is important, but also, just increasing home and community-based services is not enough to address global caregiving problems, that is caregiving shortages that are happening right now globally, and especially in the United States, and then caregiving burden for family members. And so the key existing paradigm is that, long-term care is assumed to assist or help older people with daily activities. So home care workers really help people do, shopping, do cleaning, things like that. The problem is that if you, give too much support, then that can harm actually health and function, because people tend to rely on these helpers who give support. And so in this case, it doesn't really address caregiving issues. In other words, going back to that model, survival curve model, providing support is needed for people to stay in a community, but that doesn't really move these lines. So we need a paradigm shift. And so I am interested in building health promotion into long-term care. So rather than long-term care being, providing help, we will incorporate elements that promote health, prevent, further disability, and increase function. So that is something that I'm trying to do right now. But now, who provide long-term care? In almost every country, family members are the main long-term care providers. But also, family, non-family or formal paid providers increasingly play an important role in community dwelling older adults' lives. So who are they? Who are the people who actually provide this kind of services? It's a hard work. Taking care of your own parents is challenging. And, these people are caring for others, parents or, relatives. And also I had a question about, would they be willing to expand their scope work to promote health of their clients? Because their job description simply says, well, provide these services, cleaning, cooking, helping people bathe, things like that. So I wanted to find this out. And also I wanted to see whether these home care workers can actually play the role of promoting care. So this is the program Pro Home, that I'm currently working on, and it stands for Promoting Seniors Health with Home Care Aids. And this work has been supported by NIA R21 and currently R01. And then I also acknowledge all of the people who have contributed to this study. Certainly research participants, community partners, advisory board members that represent all of these partners, and expert panel members, and previous and current members of the team. So who are home care aides? Home care aides provide housekeeping and personal care services critical for older adults to stay in the community. And I studied this series of studies with like focus groups studies that I conducted some time ago, so that I can get to know them. And one of the focus group participants said, well, clients become part of you because you be around them every day. So home care aides tend to stay with one person for longer time than, say, home health aides. Home health aides are usually working for home health agencies that provide medical care or health care in the home, whereas these home care aides work for social service agencies, so they don't work with generally, healthcare providers, licensed ones. And so here's the rationale for these programs. So I chose physical activity as a health promotion strategy because physical activity has really strong evidence of effectiveness. And older adults who have difficulties walking, bathing, do not have many opportunities to be physically active. And also there are very few programs that are appropriate for these people who may not be able to stand or walk. But physical activity is important for everybody. And for these people, for those people who are eligible for home care, these home care aides regularly provide care. So the goal of this Pro Home program is to have home care aides deliver a gentle physical activity program to delay or prevent functional declines. And also, we would like to figure out how this kind of home care aids-led physical activity program work in a real-world home care setting. And the long-term goal is to, again, build health promotion into long-term care to improve the well-being of caregivers and care recipients. Because, working with care recipients to do health promotion activities also possibly have spillover effects so that they will do more exercise. And also, I wanted to empower and engage frontline direct workers in quality improvement. So let me talk a little bit about this context of this project. We conduct this study in the community care program, which is a public program administered by Illinois Department of Aging. And this program helps older citizens who might otherwise need nursing home care, and they need to be age 60 or older, and the counted assets should be $17,500 or less. And this includes in-home services, which is basically general non-medical support by supervised home care aides who have received specialized training. And there are 15 hours of pre-service requirement, and then 12 hours of in-service training requirement annually. And this program is funded by Medicaid and the state. So we partner with the state and home care agencies and community-based organizations, especially those that do care needs assessment, and then conduct this study. And then the exercise, physical activity program that I chose is Healthy Moves for Aging Well. This is a safe in-home physical activity intervention developed and tested by California organization Partners in Care Foundation, specifically designed to enhance activity level of frail, high-risk sedentary seniors or older adults living at home in California. And this program was endorsed by the Federal Administration on Aging and National Council on Aging Evidence-Based Prevention Initiative. And it was originally delivered by case managers in a Medicaid program in California, because in California, home care aides are usually not really employed by agencies in general. And in our project that is done in Illinois, Healthy Moves is delivered by home care aides who may be family members or non-family members. Actually, family members can be paid to provide home care in Illinois. And so Healthy Moves has been adapted to suit this situation in Illinois. So we started with the pilot program. Basically, we wanted to assess and enhance the feasibility of the intervention and measurement. And this was a pre-post design. I started with the design of this randomized control trial because this Healthy Moves has never been tested in randomized control trial. And it was basically testing this pre and post kind of design. So I proposed that, but people, reviewers didn't really believe that home care aides can do this kind of thing. So it has taken years to get a funding, and then we started with R21 instead of R01. And then it became a prelude to our ongoing randomized control trial. So this is the pilot participant characteristics, and we focused on English-speaking people in the pilot. And this is just to give you a sense of whom we target this program. So the clients are mainly female African-American people living in Chicago. And typically they have a high school education, and then Medicare, 90% is Medicare eligible, and about more than half was Medicaid eligible. And both, about 50% of people are dual eligible, meaning they have both Medicare and Medicaid. And many have, basically all of them have more than 2 chronic conditions. And what is interesting is home care aides, they are not surprisingly female African-Americans generally, but also amazingly high number of people are actually receiving Medicaid. And as you can see, 30% have Medicare, meaning there are quite a bit of older people. So as you can see, the age range was 22 to 73, meaning 73-year-old home care aide may be caring for like 63-year-old client. So in general, these home care aides are older than home health aides or nursing home aides. So this shows how our intervention looks like. And so we train home care aides in in-service training, and because there are 12 hours of required training, so we use this required hours to provide training. That is also an incentive for home care aides to participate in our study. And so we do this half-day training to learn about the program and actually do hands-on role plays so that they can, deliver the program the next day when they visit their client. And this program includes 2 components. One is motivational enhancement. basically we all know that physical activity is important, including myself, but that doesn't mean that I do physical activity every day. So the first thing is to engage all the sedentary people in the conversation of physical activity. So we provide specific tools to do that. And then we teach 3 moves. It's very simple. I chose healthy moves because that was the only one that was easy enough for home care aides to deliver. And currently home care aides do not have physical activity as a kind of things to do during the work hours, and we couldn't use time that is paid by the state to do this program, so we needed to have very quick one, and then remind and encourage for the next 4 months. So this should be done without really sitting down and spending time with the clients, but while cooking, Mr. Jones, did you do physical activity today, healthy moves today? And then, oh, you haven't done that. Then I will, watch you here, and why don't you do that kind of thing, so that they can continue doing their work while they play the role of a coach or supporter for this program. And then after 4 months, home care aides were gathered again for another in-service training so that they can share with us their experience. And we did focus groups in this case, and also each home care aides actually shared tips with each other, and then they got certificates. So this is the intervention program. So it's a very simple program. And then client assessments included phone screening and then in-home screening, and did informed consent, and we did baseline assessment, and we tried to capture health information from self-reports as well as performance-based tests. And then we did post-intervention assessment. So we trained interviewers to do all of this training, all of these assessments using the tablet. So I would like to share briefly the pilot results, and we got very good results. So this is still pre and post design. So there are lots of confounders, but clients' health outcomes improved after the 4-month intervention in terms of daily activity function, that is self-report, and physical performance that included, walking speed and other physical performance tests. Self-rated health, pain, fear of falling, all improved. And then clients were satisfied with the intervention, and this program was well received by home care aides as well. So with this result, we could get the next level of funding. But here are some of the things that clients shared with us. One of the clients said, I feel like I gained some confidence from the program. I feel like I do not need my cane as much as in the morning. Another person said, I like the way it made me feel. It gave me something to look forward to. I feel like it strengthened me. Home care aides also, positively, evaluated this program. One of them said, my client is a 90-year-old gentleman and he loves the program. He reminds me most of the time. In fact, it helps him and it helps me as well because I always do it with him. So this is an indication of spillover effect on home care aides. Another person said, my client is a diabetic and she's on the dialysis machine. Sometimes she tells me, I'm tired. So I say, okay, we're gonna get some rest. And then she'll say, we're gonna do one more with the feet. I say, okay. So I let her go at her pace. So, so it's interesting that the physical activity increased in home care aides, not for younger ones, but people, home care aides who are older. So that was a positive effect on home care aides. So for more details, we have publications from this pilot studies. So now we've moved to ProHome, randomized control trial, and we have been doing this trial in a real world policy, publicly funded home care setting, the same setting as I talked about. And this time we have Active Mind, which is a attention control, and we included Spanish version of the program. And I learned that actually having another language version has more than double the amount of work that we need to do, but it was very really great to have more people participating. And also we added a month for home care training so that they have some refresher or boost up training. And then we studied the randomized control trial with focus groups. We did develop both programs materials, and we did a mock training session, and also we did mock assessment of home care aides. And this is what I heard, that this program should be part of the care plan. The program should be mandatory for all home care aides, or when is this going to be implemented as part of regular home care services. So we got a very good response, and we studied the program. Now, well, this program actually started before the COVID. And as you saw, stakeholders like the program, and all of these stakeholder organizations are excited about the program. However, conducting a randomized control trial in a real world community setting is challenging, and especially the recruitment. The bottleneck for recruitment is basically, as an outside organization, we cannot have a contact information of the client. So what happens is that, our team wants to contact people who need this kind of services or a program. And we provide ProHome information. We would like to. And home care agency has the contact information, of course. But, we cannot really get the personal information from the home care agency. And so we ask them to send letters and supervisors to call them. And sometimes supervisor home visits can include some explanation and things like that. But the state requires written consent to release contact information to UIC, meaning written, meaning getting the wet signature from homebound person, and we cannot ask home care aides who are also participants. So that was a huge barrier, because home care agencies do not have extra workers to do this kind of thing. And so basically we needed to get this written consent in order to get contact information. So that was a major barrier. And so UIC was unable to reach the majority of potential participants who could benefit from ProHome. So that is a major, bottleneck. And we tried to ask for, removing this written consent part so that we could do, just verbal phone consent. We tried again and again, but it didn't work from the legal team. So, and that actually changed. What was impossible was changed by COVID, but that was another story later. And also changes in American healthcare really pose challenges and opportunities. States are transforming care for Medicaid beneficiaries with chronic disease and disabilities. And Illinois is one of the states that really transition from social service type care to managed care. And also, of course, this issue has been here for decades, the fragmented systems of long-term care, and also access to long-term care is limited to those people who are eligible for Medicaid or certain state programs. And so basically, that was a big challenge. And COVID hit us, and so we immediately stopped in-person contacts between the research team and the participants. And we pivoted to all of this remote intervention. So the in-service training is now done by Zoom, but home care is essential workers, and they continue to visit the homes of home care clients. Otherwise, they cannot really get paid. So there are lots of issues that we observed. We really learned a lot about what's actually happening in this COVID situation. But basically, ProHome continued the same way. And then basically, what changed is the interviews. So basically, research component, getting assessment, we can no longer do performance-based tests. So that was unfortunate because we developed the measurements, but we couldn't continue. We need to stop some of these measurements that require in-person contacts. And we tried to change some of those, but the self-reported ones could be done via using the phone. So what we learned during this COVID era following. So home care aides were the only healthcare providers visiting older adults in their homes at the outset of the pandemic. Home health therapists stopped, visiting, but still home care aides were going. And ProHome continues to work well remotely, and we could preserve this in-person, interaction between the pairs, home care aides and home care clients. And at the same time, COVID-19 exposed ongoing issues in long-term care. They were there all the time, but actually it highlighted all of these issues, like low pace of home care aides and all kinds of difficulties. So and also there are lots of staff turnover in agencies. That was another difficult aspect of recruitment, because we need to talk to them and introduce the program and do all these onboarding activities, including some IRB type training, but that became even worse during the COVID era. So COVID-19's impact still continues. Worker shortages in collaborating agencies, state agencies have to continue to adapt to evolving situations, and state, these mandates and new COVID variants coming in, all kinds of policy changes affect our study deeply, because one of them is that home care aides in-service training was kind of somewhat waived or could be changed. And so before, training had to be in person, now remote, and it's easier to do remote training. And also they reduced the required in-service hours. So towards the end of this intervention, home care aides have already satisfied this year's in-service training hours. So ProHome training no longer counts towards required training hours. So that is another challenge that we had during this COVID. So what have we learned so far? The concept of building health promotion into long-term care, home care, is pretty easy, simple, and attractive, but it's not easy to do research to produce evidence. Well, first of all, recruitment is challenging, and so far we have randomized 128 diets, but this required real, lots of energy and time and persistence. And we are recruiting dyads, meaning both of them need to be interested and both of them needs to be, able to continue. And we are dealing with frail older people. They get sick, they get hospitalized. Home care aides have all kinds of issues, especially, during the COVID situations, all kinds of things happen around them. So that was challenging, but this kind of program was totally new to us, researchers, as well as for other organizations, all the partners. So it is important to learn together. And so that is a motivation for us and for them as well. And so everybody gets the same kind of experience. Oh, this is totally new situation. So so that is one important thing that we learned. Community-based randomized control trial that involves older adults with multiple disabilities and mobilities is challenging but rewarding in terms of when we see the results or reaction of people. It's really rewarding. And also, it was unfortunate to get into these COVID situations, but also that was a really amazing window of opportunity for us to be able to learn what is actually happening. So challenges, we already talked about recruitment issues, but there's a huge variation across these participants, different languages and literacy level. Some people, like home cares, may not be able to actually read the material. So we needed to really modify the material so that they can understand. And also, the turbulent healthcare environment continues. So we've learned a lot. And we will find out whether this pro-home program delays functional declines and improves the quality of life of those people who are living in this area between the lines. But the data, we closed this initial recruitment, and then we will follow up for 8 months, and then we will get the data. And so the answer is still unknown, so stay tuned. And so our current and future directions include adapting the program to people with cognitive impairment. We know that people with some cognitive impairment can do this kind of activities because some of the participants actually had declined cognitive function during the program, and they could still do it. Then exploring additional strategies to building health promotion into long-term care. That is another thing that we are continuing. Assistive technology, so that doesn't rely on people or caregivers, but assistive technology can really, help people to engage in health promotion activities, and also that can help caregivers. And also policies to promote community-based systems. That is an important area to explore. And also learning from each other with global communities, because we are in a really unprecedented time. No country, no societies have really faced this kind of society with lots of older people, more older people than younger people. So to conclude, community-based intervention takes time and energy and is rewarding, and partnership with trusted individuals is essential in recruiting, data collection, follow-up, scheduling, and multiple research approaches help deepen our inquiries, and co-learning is critical locally, globally. And learning from other societies is essential in the area of global aging. And I would like to share some experience going to China as a delegate, a member of the delegation of the Chicago Sister Cities International's Social Service Exchange Program. And this is a two-way learning program. Every year, we send a delegation team to Shanghai, and Shanghai will send us people to Chicago. And so I happened to be there in October 2015 when China discontinued the one-child policy. And it was really life-changing kind of opportunity for me. So this is the picture of park in Shanghai. And as you can see, there's a playground for kids, no kids around. It's surrounded by people who are older doing exercise. And so here's this, adults playground. And so there's this machine, and you can actually hear the music, and also you can kind of follow the screen to do exercise, right? And then, so this is the kind of scene that I observed, and I was just so amazed by the scene. And so this kind of equipment is, in the park, and this is something that we really wanted to bring back to Chicago. And there's actually there's a park that will have adult playground in the city of Chicago. So thank you very much for your time, and I would like to get any questions or any comments. I would appreciate it. Thank you very much.